Hola, muy buenos días y bienvenidos
Good
al webinar de
morning,
la Organización Panamericana
and
de
welcome to
Salud
the
sobre
webinar of the
prevención
Pan
del
American
cáncer
Health
uterino en las
Organization
Américas, estrategias
seminar
claves
on
para
the prevention
para
of
su
cervical
eliminación.
cancer in the
Soy
Americas,
Silvana
key
Luciani del
strategies
Programa
for
de
its
Enfermedades no
elimination. I am
transmisibles de la
Silvana
Organización
Luciani, the
Panamericana de
head
Salud
of the
y estoy acompañada
non-communicable
en este
diseases
webinar
of
con mis
the
colegas del Programa de
Organization of
Enfermedades
Pan
no
American Health,
Transmisibles
and I
junto
am
con
joined by
los colegas
other
del Programa de
colleagues from the
Inmunizaciones de
program
la
of
OPS Washington, D.C.
immunization
Y
of
es un placer
in
darles la
PAHO.
bienvenida a
It's a
este
pleasure
webinar.
to welcome you
Pero
to
antes
this
de
webinar.
empezar,
But before we
queremos
begin,
reforzar
we'd
que
like
tenemos
to
traducción
emphasize that
simultánea.
we
La
have
sesión será en inglés,
simultaneous
en
interpretation. The
español,
session will be given in
portugués y
English,
en
Spanish,
francés. Así
Portuguese,
que
and French.
al fondo, en
So
el globo,
in the
donde dice
background at the
interpretación,
bottom,
se puede
where you see a
elegir el
little world
canal
globe,
de su
and it says
idioma.
interpretation, please select
Good
the
day and
language you
welcome to
prefer.
the PAHO webinar on cervical cancer prevention in the Americas, strategies for its elimination. I'm Silvana Luciani from the NCD program in Washington, D.C., and it's a pleasure to be here connected with my colleagues from the NCD program as well as the immunization program. And I just want to let everybody know that we will have this webinar in our official languages of English, Portuguese, Spanish, and French. And you can select the language of your choice using the interpretation button at the bottom of your Zoom. Bueno, para empezar, estamos haciendo este webinar en conmemoración de
To begin,
la Semana de
we are
Vacunación
organizing this
en las
webinar
Américas
to
que se
celebrate
celebra cada
Vaccination
año
Week in the
para crear
Americas, a week
conciencia
that's
sobre la
celebrated
importancia
every
de la
year
inmunización.
to
Y lo
emphasize
que
the
nos
importance of
une hoy día
immunization.
es la
And what brings us
preocupación que
together
tenemos
today
con la
is the
alarmante
concern we
de
have
cáncer
with the
cervicuterino,
very
a
alarming
pesar de que se puede
number of
prevenirla con la
cervical
vacuna contra
cancer
el
cases,
VPH
even though it
junto
can be
con el
prevented
tamizaje y
with the
tratamiento
HPV
oportuno.
vaccine
Así que en este
with
webinar
screening
vamos
and
a presentar las
timely
estrategias para
treatment. So
prevenir
on
el
this
cáncer
webinar, we will be
cervicuterino y
talking about the
también presentar
strategies to
algunos
prevent
ejemplos de países que
cervical
están
cancer and talk
progresando
about some
hacia la
countries that have
eliminación.
made progress
Para
towards
dar inicio a
elimination.
este webinar,
And to
quiero
begin
invitar al
the
Dr. Hugo
webinar, I'd
Rasuri,
like to
gerente
invite
adjunto
Dr.
del
Hugo
programa de
Rasuri,
inmunizaciones,
Assistant
para darnos las
Manager
palabras.
of the Immunization Program, to welcome us.
Muchas gracias,
Hugo.
Silvana, por la
Thank you,
introducción
Silvana, for
y
this
estimadas
introduction.
y estimados todos,
And
muy buenos
my
días
dear
y es un
colleagues,
placer darles la
welcome. It's a
bienvenida a este
pleasure
webinar sobre
to welcome you
prevención
to
del
this
cáncer
webinar on the
cervicuterino
prevention of
organizado en el
cervical
marco
cancer that
de la
has been
23ª
organized under the
Semana de
framework
Vacunación de las
of
Américas.
the uh,
Hoy tenemos la
23rd
oportunidad de abordar uno de los
Vaccination Week of the
desafíos
Americas.
más
Today,
significativos del
we
futuro, que es
have
el cáncer
to
cervicuterino.
deal
Este
with
tipo de
one of
cáncer
the
es una de
major
las principales
challenges we
causas
have,
de
cervical
muerte
cancer. It's
de
one of the
mujeres a nivel
main
mundial y en
reasons for
nuestra
death
región
of
afecta a casi
women worldwide. And in
79.000
our region, it
mujeres
affects almost
y ocasiona
79,000 women,
casi
and
40.000
it
muertes al año.
leads to almost
En América
40,000
Latina y el
deaths per
Caribe,
year.
la
In
incidencia de
Latin
cáncer
America and the
cervicuterino varía
Caribbean,
entre
the
países, con
incidence of
tasas que oscilan entre
cancer, it
7 y
varies
39
in
casos
countries
nuevos por
in
cada
rates of
100.000
7
mujeres,
to 39 new
siendo
cases per every
lamentablemente la
100,000
segunda
women.
región del mundo
And
con más
unfortunately, we
incidencia y
are the
mortalidad
second
en cervical.
highest rate
En
of
respuesta a esta situación, la
cervical cancer in
Organización
the world.
Panamericana de la Salud,
In
dentro del
response to
marco
this,
de
the
la
World Health
iniciativa de
Organization, under
eliminación de
the framework
enfermedades,
of the elimination of
viene
diseases,
apoyando a los
has
países de
been
la región a
supporting
implementar
countries
la
in our
estrategia para
region
la
to
eliminación
help
del
them
cáncer
implement the
cervicuterino.
strategy for the
Esta
elimination of
establece
cervical
la
cancer.
meta de
It
alcanzar
has set a
una tasa de
goal of
incidencia de
attaining
menos de
a
4 casos
prevalence rate
por
of
cada
less than
100.000
4
mujeres.
cases per
Y tenemos tres
100,000
objetivos
women.
claves para
And
el
we have
año
three key goals
2030.
for the year
El
2030.
primero, al
The
menos
first
lograr un
goal is to
90% de
attain at
cobertura
least
de la vacunación
90%
contra el VPH en
coverage
niñas
of
para los 15
vaccination
años.
against
El
HPV in
segundo, tenemos
girls by the age
70%
of
de cobertura
15.
de tamizaje
Second,
como una
have a
prueba de alto
70%
rendimiento.
screening with a high
Y el
yield
tercero,
test of
tener el
women between
90% de
35 and 45.
tratamiento
And
de
third
selecciones
goal,
precancerosas y de
90% of
cánceres
treatment of
basales.
precancerous
En
and
las últimas
cancerous
décadas hemos logrado
lesions in
avances
women. In
significativos en la
the
prevención y
latest
control de este
decades, we
tipo de
have
cáncer
achieved
con la
significant
introducción de la vacuna del
prevention
virus
of
del
cancer
papiloma
with the
humano
introduction
y la
of the
implementación de
HPV
pruebas de
vaccine
detección más
and
efectivas.
the
Sin
implementation of much more
embargo, la
effective
cobertura
detection
de la
tests.
vacunación
However,
sigue siendo
the
desigual
coverage
entre
of the
países y
vaccine
dentro de
is
ellos. Y
uneven in
muchas
countries
mujeres
and even
aún no
within
tienen
countries, and
acceso
many
a
women
programas de
still don't
tamizajes
have
adecuados.
access to
appropriate screening tests. Our director, Director Gervas Barbosa, has made a continuous commitment and a strong commitment to this topic and has said that our region could become the first region in the world in eliminating cervical cancer. The first World Forum on the Elimination of Cervical Cancer took place in Colombia last year, and it shows the commitment that our member states have to this very important and praiseworthy goal. This webinar, it gives us the opportunity to share information on the status of the programs to eliminate cervical cancer in the Americas. We'll also be talking about key prevention strategies, screening, treatment, and some challenges and opportunities to attain its elimination. We thank you very much, therefore, for your participation and your commitment to this very important initiative. I think that working together, we can move towards a future where cervical cancer is no longer a threat to the health of our women. And remember that our motto of this vaccination week is our decisions make a difference. Thank you very much. Thank you, Dr. Rasuri, for these words of welcome to this webinar on cervical cancer and the strategies to eliminate them. And thank you for emphasizing the global strategy to eliminate cervical cancer by emphasizing that we have to increase HPV vaccination coverage up to 90% in girls under the age of 15 and to increase screening by 70% for women at the age of 35 to 45 years old, and to increase the treatment by 90%. And thank you for motivating us to encourage us to become the first region to eliminate cervical cancer. We know that of all the regions in the world, the Americans are a bit more advanced in other areas. In the last few decades, we have advanced with the introduction of the vaccine against HPV and the more effective detection tests, better than the traditional ones. And yet, we still have many challenges before us to attain the complete elimination goal. So to update us on this situation, what the situation is in the Americas, I'd like to invite Dr. Natalia Katz and Dr. Mauricio Massa of PAHO to describe the situation regarding cervical cancer and what progress we're making to eliminating it in our region. Natalia, thank you. Silvana, let me share my screen.
¿Se ve en pantalla completa?
Can you see the full screen? No, we don't see it.
¿No?
Ahora sí.
¿Sí? Ah, está un poco lento. Sí, está perfecto. Bueno, bueno, muchísimas gracias, Silvana.
Thank you very
Muchas
much,
gracias,
Silvana.
Hugo. Un poco,
Thank you, Hugo.
ahora con Mauricio lo que vamos a hacer es dar,
What
como
Mauricio and
decía
I will be
Silvana,
doing is, as
un
Silvana
diagnóstico de
said,
situación o una situación en cuanto
we'll
a
diagnose the
características
situation
importantes para
dealing with
las
the
estrategias
very
que tienen que
important
ver con la eliminación de
pillars
cáncer cervical de
for
mama.
the strategies to eliminate
Vamos a
cervical
hablar de la
cancer.
estrategia
We'll be
mundial que ya
talking
ha
about the
sido
global
nombrada
strategy,
y
which has
dividir un
already
poco
been
estos
mentioned,
tres
and
pilares
then we
fundamentales
will
para
divide the
lograr la
three,
meta.
talk about the three basic
Cuando
pillars for
hablamos
attaining
de
our
cáncer
goal. When we
cervicouterino,
talk about cervical
también es
cancer,
importante
it's important
hacer un enfoque,
also
¿no? Que tiene que ver con el
to
curso de vida para las intervenciones
focus
dentro
the
del
fact that
cáncer.
it has to do with the life
Digamos,
course
este virus tiene una
in
particularidad
interventions
de
for
que
cancer.
no
This
es, digamos,
unique aspect
una
of this
patología aguda,
virus
sino tiene una
is
historia
that it's not
natural
an
que va y
acute
transcurre a lo largo de
pathology. It
los
has a
años de
natural
la
history
mujer,
that
¿no?
occurs
Tenemos
over the
protección
life
por
course of a
VPH
woman. It was
alrededor
prevention
generalmente de los 15 años con el
through
inicio de las relaciones
to
sexuales
the
y
beginning with
entre
sexual
10
relations
años
and
después
the
aparecen las
introduction to
lesiones
HPV. And then about
precancerosas
10 years
y
later, the precancerous
más o
lesions
menos a
begin
los
to
15,
appear.
20 años de
And at about
infección por
15 to 20
VPH
years
puede
after
aparecer un
having been
cáncer.
infected,
Esto,
the
como
cancer
saben,
itself
el VPH
appears.
es
As you know,
sumamente
HPV
frecuente en
is
toda la
a very
población
frequent
y el
throughout the
90%
population,
se
and
autolimita, pero entre un
90%
5 y un
uh,
10% produce una
don't
infección
have
crónica
it
que puede
as
llevar a
self-limiting preventing, but in 60% it could become a chronic disease and lead to cancer. So the health prevention could occur at the three levels: primary care through vaccines before infection takes place. The ideal would be before the age of 15, where it has the biggest impact to prevent HPV infection. So that's primary prevention. Then we have what we call secondary prevention, women beginning at 30 with the detection through screening of HPV treatment or precancerous lesions. And then the third stage is timely treatment, diagnosis, and follow-up in at least 90% of the women who have received a cancer diagnosis. So keeping in mind these three pillars that we've already talked about, the 90-70-90, that's the global strategy for the elimination of cervical cancer. And to attain that goal, which be to have less than 4 cases per 100,000 women per year, we need to achieve our goals of 90-70-90 by 2030. That means 90% of girls fully vaccinated by age 15, 70% of the women subject to a high yield test for HPV twice in their lives at 35 and 45 years of age. And then 90% of the women that have been identified with cervical disease to be identified, receive treatment, care, and follow up. So to describe the burden of cervical cancer, we are going to talk specifically about the incidence of it. We see that more than 170,000 women are diagnosed every year with cervical cancer. When we talk about this incidence, you'll see that it's not homogeneous. This is a disease that very clearly demonstrates there are inequities. And in the areas of the world with lower income levels, we have greater incidence, and we see this in sub-Saharan Africa and some areas of Latin America. And when we go to the Americas, the incidence is more than 78,000 diagnoses per year. And then when what Hugo was saying, that when we look at each one of the countries, we have some countries that are very high, far above the median in the Americas. In America, it's 11 per 100,000 women. Some countries that are way above that. And then there's some that are way below that figure. Now, when we dig down into each one of the countries, we'll see the same heterogeneous distribution depending on the state, the municipality, or province.
Here on this slide, we can see the mortality. We're talking about the mortality rates. It has a mortality rate of about 50% in terms of incidence, and more than 40,000 women die from the disease in the Americas per year. Now, here you can see a breakdown regarding mortality, and you can see heterogeneity in terms of the cases. Now, here, turning to pillar number 1 specifically, that is primary prevention. The idea is to avoid the infection. And these vaccines, what they have in common, the vaccines against HPV, is that they are vaccines using recombinant technology. And what they do is they produce very similar particles that are very virus-like. And these technologies are expressed through using different substrates, for example, insect cells or yeast or E. coli. Now, here there is a division according to the genotype in terms of the vaccine-like particles, and what we see is bivalent 16 and 18, quadrivalent, they have to do with cervical cancer. And when we add genotypes 6, 11, and 16 and 18, that is in the quadrivalent vaccine. And then the final one that is being developed, something that is available now through the revolving fund, is the non-valent, which adds these genotypes. They have a high risk of evolving into cancer, and that adds coverage that goes from 70% in bivalent or quadrivalent vaccines to 90%. That is the coverage that is obtained with the genotypes causing cervical cancer. Now, there is an adjuvant in these vaccines. As you know, what that does is increase the valency, and all of these vaccines were highly effective in tests, and they were immunogenic with a zero conversion of almost 100%, and they are highly safe. This is the status in terms of vaccination on national calendars. This is in green, the countries that have put this vaccine on the national calendars. Of 194, 147 say this is being done at the national level. That means that these countries, 75%, have incorporated the vaccine. And you can see that the Americas are truly an example. We'll look at this in greater detail later on. But in other regions, on other continents, there are still some countries that have yet to include the vaccine. This is what I was saying about our being an example. Here, out of the countries, the territories within the region, 48 countries have already incorporated the vaccine. 2 countries are just about to do so. So we have almost all of the countries in the region that have already incorporated this vaccine on their national vaccination calendar. Now, this is a timeline. It shows the progress. Here from 2006, incorporating it in only 2 countries, and then progressively, you can see that by 2023, we're at 48 countries that have this vaccine on their calendars. And then something very significant is the strategy being used for vaccination. And what we can see is that 73% of the countries that follow the strategy do so as part of a school vaccination campaign. Another 15% treat only in health centers. 9% have a mixed strategy combining the school strategy with the health center strategy. Now, when we look at coverage, here we can see 2 graphs. Here on the left, this has to do with program coverage. In other words, this is something reported by all countries. And then here on the right, you can see a calculation that has to do with coverage at the age of 15. And as we can see in light blue, that's the first dose in women, we have a 68% program coverage. And here at age 15, the coverage is 77%. Now that is as we work towards our target, which is 90%. That means that we still have room for improvement regarding coverage. Here, this is complete dose coverage and coverage in males, which is below the coverage for females. Now, another important thing that has to do with analyzing the evidence and all of the dynamic changes having to do with this, here we have SAGE, that is our strategic advisory group of experts on immunization. They issued a communique in April of 2022, and it was published in December of that same year. There was a position paper on the part of the WHO, and they also reinforced that last year. Now, here, as we know, the prioritized population is complete coverage before the age of 15. In other words, before contact with the virus with a 2-dose arrangement. Now, we know that 1 dose is also acceptable. It is outside of the prospectus. It's off-label, but the effectiveness, the immunogenicity studies have shown that 1 dose is just as effective as 2 doses or more. And that recommendation holds up to the age of 20. After 20, then 2 doses are required. In immunocompromised persons, there can be at least 2 doses given, ideally 3 doses. Now, the Technical Advisory Group of the Pan American Health Organization issued a communique following a meeting of experts in May of 2023, stating that all countries should guarantee at least 1 dose to girls between the ages of 9 and 14. And the same is said about the immunocompromised population. They should receive at least 2 doses, and if possible, 3 doses. Now, as I was saying, that document was issued in December of 2022. That was the document from WHO. It talks about different bivalent, quadrivalent, and then in October of last year, it added the nonavalent vaccine. Now, those that we are discussing are currently available in the revolving fund of the Pan American Health Organization. So exactly where do we stand in terms of this single-dose vaccine? We can see that here in the Americas, many countries have shifted to one-dose regimes. Now, many of the countries that have this vaccine on their vaccine list, they are using a single dose. Now, other countries and other regions have done the same. Something else that is very important is vaccination against HPV by gender. Here we can see 32 countries, at least 32 countries in the Americas also vaccinate males. So when we look globally at this, more or less one half of the countries have incorporated males and included them in this strategy. So, highlights. First of all, 48, in other words, almost all of the 51 countries have introduced HPV vaccines on their national calendar. More than 50% of the countries that have the vaccine on their calendar have switched to a single dose system, and 3 of every 5 countries have a strategy that is gender neutral. Now, to conclude this part of Pillar 1, the idea is that we have to reach our objective of 90%. We still need to make efforts in each and every country of the region so as to improve coverage and reach the 90% target. Training health teams vaccinating against HPV is essential. Communication with the community is very important. Communicating the idea that we need to eliminate cancer, that's an important argument in all countries, and it's a message that has to be adapted to the local community. And we also need to strengthen in-school vaccination. There is evidence that that is the most effective strategy, but it's not the only one, and it's not sufficient. So we need to strengthen in-school vaccination, but also we have to make certain that we can cover the non-school population or the people not vaccinated at school. We have to realize that a single dose regime can be more advantageous, and they may be more efficient, more affordable. They may allow us to improve coverage, promote health equity, and it may allow us to incorporate other populations, unvaccinated, women over the age of 19, add males in those countries that have not done so yet, and also to deal with the immunocompromised at all ages. So with that, I give the floor to Mauricio so that he can continue to present the other pillars. Thank you, Natalia. That was a wonderful introduction, and I'm going to continue by discussing the other 2 pillars with you. I only wanted to make sure that you are able to see my screen. We can see it quite well. Thank you. Okay, so now going to Pillar 2, it's important to always remember our goals, the 90, 70, 90, and I'm going to be focusing on the 70% that has to do with screening and 90%, which is treatment and review to make this possible. We had our WHO guidelines, and they were updated when we launched the global strategy to accelerate the elimination of HPV. And now we have updated guidelines for screening and also for treating precancerous lesions. But the overarching objectives or the message of these guidelines is that there has to be a transition. in the general population and also with women, for example, living with HIV. The recommendation is to have a transition where we can do visual inspection with acetic acid or cytology to detect HPV. When an analysis was done at the global level in 2020, as you can see worldwide, using screening for HPV was limited. And the countries where there was a stronger transition towards using the test, those were countries like Australia, United States, developed European countries, and the countries where there were greater needs. There were no official recommendations, for example, like in Africa, and we in Latin America had seen greater activity. We were working with HPV, and cytology was the main tool used. Now, as Natalia was saying in her presentation, it has taken many years to reach a situation where most countries have HPV vaccine. And now we're talking about the processes to make certain that the 90% of coverage will be reached. We, as a region, fortunately, most of the countries already have projects where they are using human papilloma virus testing. And there are some countries that are already including this in their national implementation plans. Now, these are preliminary data. We'll update this. We know that countries like Uruguay, Honduras is also presenting today, are including this in their programs. Jamaica, too. And we hope that by the end of this year, we'll be able to update this map and we will see more countries in dark blue. Brazil is making many efforts. They are trying to produce the first test at the regional level. And that's going to change a lot of the colors on this map, and that is a good thing for us. Now, we as an organization, how are we supporting the countries? As you know, we have our revolving funds, and we provide not only support in terms of affordable testing materials, but this also goes hand in hand with technical support. As an organization, first and foremost, we collaborate in terms of providing a good approach, a general approach. That is what we want to do, looking at elimination, vaccination, screening, treatment, and we help countries plan for their needs. Now, based on this, we, through the strategic fund, part of the regional revolving funds, we can offer tests that are pre-qualified by WHO, and we do so at lower prices. So when we talk about screening, we know that fortunately, most of the countries of the region are already introducing these tests. Unfortunately, not all countries have adopted the tests, but as I was saying, I think this is something that is going to change with time. And we, through the organization, can provide technical support and also access to tests at a lower cost. I think that currently, thanks to the negotiations that have been ongoing, I think we're going to be able to offer HPV tests in a way that they will be affordable to all the countries of the region. And when we talk about treatment and when we think of cancer, as Natalia was saying, fortunately, because of the natural history, and this is a reason that allows us to eliminate this cancer through vaccination and screening, this requires treating before it is a cancer, when it's in a precancerous stage. And that means we can lower mortality in the short term for the women in the region. And that is part of the guidelines that were updated when the strategy to accelerate the elimination was put in place. The idea is to work with the most recent evidence, looking at how to deal with these precancerous lesions and how to include this in screening. And basically, here we can screen using an HPV test and then treat if we find abnormal results. And also we can do screening, provide triage, and then treat according to the results.
Now, how the countries will do this, it will depend a lot on the resources the countries have to decide how to handle this. Why? Because we know that the more steps we add to the screening process, screening to treatment, the greater the possibility women may be lost in the process. That's why we have encouraged to try to ensure that most of the management be done at the primary health care unit. Here, for instance, you have two algorithms. The one on the left is much simpler. It's from the HIV test to determine if it can be treated and then treat those who are positive. On the right, you'll see another algorithm where you do triage based on the type of genotype and then do additional testing and to continue doing triage. The message here is that this is one of several algorithms, and there are many different ways of addressing the problem, and each country must do it based on its ability to treat with women who have abnormal tests. We can't reach the goal of 70% screening if we're not able to reach 90% treatment. And what evidence has shown us is that whatever algorithm you choose, we have enough evidence that you can prevent cancer and save lives. Why? Because although we need to emphasize on the importance of invasive cancer treatment, but it's only during the precancerous phase and stage that we have the best impact possible. When I talk about the impact or the scope at the tertiary level, which would end up requiring surgery, chemotherapy, radiotherapy, etc., you can see that in most of our countries in the region, they do have some access to that, but for instance, in the Caribbean, access to radiotherapy is very difficult. So, and it creates many complex issues. That's why we would like to emphasize that all stages of treatment are important, but if we can focus and prevent secondary occurrence before we reach the tertiary, it's very important. We also will share with you some links so that you can see that thanks to its support, we have translated all documents on the standards, on the thermocoagulation guides, the introduction of HPV tests, and through the strategic fund, we now are able to offer colposcopes, thermocoagulators, electrosurgical generators, which can be applied at the primary, secondary level if necessary. So I wanted to highlight, therefore, that there are several options for algorithms to manage precancerous lesions. A lot will depend on the resources of each country. Several countries have access to treatment, but in the cases of the Caribbean, access to treatment is limited. But through the strategic fund and the revolving fund, we now can offer, in addition to help with vaccines, tests for HPV and the equipment that may be needed, thermocoagulators, colposcopes, etc. So to conclude, this is a moment to highlight opportunities. We know that without the vaccine, there's no elimination. And we know that without improving our screening and treatment systems, we will be leaving a generation of vulnerable women who have not received the vaccine the fate of dying with a disease that's preventable. So we can use the technology available to us. It can be used at the level of primary health care for screening and treatment as well. It's not something that we shouldn't have happen. We have the tools in hand, we have the money, and we hope the countries can benefit from this. I am sure that today we will be hearing from the various countries and what their status is. Thank you very much, Dr. Massa and Dr. Katz, for this excellent summary on the cervical uterine cancer in the region and the recommendations for introducing the HPV vaccine using a single dose vaccine and to introducing screening tests so to ensure that all women who have been detected to have precancerous lesions or cancer can be treated. Excellent summary. Thank you very much. We now invite those of you who are working in the ministries of health programs, we invite you to use the strategic funds of PAHO, not only for purchasing the vaccine against HPV, but as Dr. Massa said, there are monies available for equipment to treat cancerous lesions. So our staff is here to help you in attaining the elimination of HPV cancer and access to these medical technologies. Well, now let's move on to hearing about the experiences that the countries in the region have had.
Invite our colleagues from the Caribbean, from St. Lucia, Julieta Cassius Frederick, who is the Principal Nursing Officer for Primary Care in the Ministry of Health, Wellness, and Elderly Affairs, to talk about how in St. Lucia they're working hard to eliminate cervical cancer. Welcome, Julieta, and over to you for your presentation.
Thank you very much. Can you hear me clearly?
Yes.
Okay. Thank you and good day to all. And thank you to PAO and WHO for the opportunity to present today and give St. Lucia's situation as it relates to cervical cancer. Do I go ahead and share my slide, or is being shared on the other end?
If you could share it, that would be best. Are you seeing the little share button at the bottom?
Yes, I'm trying to retrieve the document.
Okay. And while you're pulling that up, I just want to comment on how excited we from the PAHO office are that Caribbean has always been a front runner leader in eliminating diseases. And we have a lot of work going on in the Caribbean countries with raising HPV vaccine coverage, with introducing HPV testing, strengthening treatment services. And so there are great expectations for the Caribbean subregion to be on the path towards elimination, leading the region once again for eliminating.
Sorry, I'm having a little difficulty in getting my slide up. So I would really appreciate if you have the presentation, if you in the interest of time, please. That's quicker.
¿Alguien tiene la presentación?
No.
Natalia? No?
No?
No, apparently we
Okay,
don't
let
have
me.
it.
I don't have the presentation.
Oh,
You want
okay.
to, if you
I'm
want
not
to send me
I'm
by
not getting
email,
to my document. I'm not getting to my documents.
Julieta, can I suggest that perhaps you send it to Natalia, and while you're doing
yes,
that,
by email.
perhaps we could go then to the next speaker and line you up after the next speaker?
Yes, this
Yeah.
is fine. Absolutely
Okay,
fine.
thank you. Thank you,
Yes,
Julieta,
thanks.
for your
Okay, yes.
accommodation.
Sorry about that.
That's okay. We understand the technical difficulties. Hola, buenos días. La doctora Jacqueline Figueroa, quien es el líder en Honduras.
Good morning, Dr. Jacqueline Figueroa, who is the head in Honduras and the Secretary of Cancer at the Ministry of Health, who has a great deal of experience in cervical cancer, will be speaking. Dr. Figueroa, good morning. Thank you very much for giving us this opportunity to participate and share the progress we have made at the Secretariat of Health in Honduras. Honduras has been focusing on this topic when we were asked to bring about a change in our implementation strategy for cervical cancer. Can you see my presentation?
Adelante.
Sí.
Muchas gracias.
Thank you.
Podríamos decir que para nuestro país el
Perhaps what we can
proceso
say is that in our country, the
de hacer un cambio viene desde
process to
temas
bring
de
about change
gobernanza, organización,
is
etcétera.
based on
Y
how the
pues
governance and
tenemos
organization,
este gran
etc.
reto
And
de
so
avanzar en
we have
reducir y llegar a esa meta de
decided
4
to
por
try to
100,000,
reduce
pero
this
todavía
and to reach
estamos
the
en un
goal of 4
proceso
per 100,000,
donde
but
nos
we're
hemos
still
preparado, nos estamos
undergoing
avanzando y
the
preparando
process of
para poder lograr ese cambio.
preparing ourselves to bring about that change.
Porque la pregunta sería si en Honduras el cáncer de
We could ask
cervix
ourselves the
es el
question
segundo más
whether
frecuente.
cervical cancer is the
Ya que
second
mama es el primero,
most frequent
pero
form of
este sigue
cancer.
siendo
Breast
la
cancer
primera
is the
causa de muerte,
first
siendo totalmente
type of cancer,
prevenible.
but it's completely preventable, and yet is a very
Entonces, ya
high reason for
desde el
death. So beginning back in
2017, creo que tuvimos estos
2017,
acercamientos con organismos
we
donde
approached
nos empiezan a
organizations
presentar la
and
oportunidad de
we
conocer
started
más
talking about the
sobre
opportunity of
las
finding
pruebas de
out
VPH
more
y
on
empezar a
tests for
organizarnos y a
HPV,
generar
and
todo
we
lo
began
que
to
teníamos que
organize
hacer
ourselves
para lograr,
and
ir logrando
prepare
y al punto donde hemos llegado y
to
todavía los retos que tenemos que
reach the
alcanzar.
point we are today
Quiero decir que
and
esta
to
estrategia,
continue working towards the goals we have set for
el
ourselves.
tema de cáncer infantil, cáncer
In
de mama,
the
no es algo que
child
solo
cancer,
viene a
breast
hacernos
cancer
un cambio al país en
are
el tema
things that
de cervicuterismo, sino que en
where we have
general
changed
para
our
la
attitude in our
población. Y
country,
ya contamos con la ley
and we
la ley de atención al paciente oncológico,
now have
el
a
cual el
law
año
on
pasado
care
el
for
Congreso
cancer
Nacional
patients, which was a
por
law
unanimidad
adopted
aprueba
unanimously by
el reglamento de
the
ley que estamos ya
Parliament,
casi
the
en el
National
proceso de
Legislature last
finalizar
year.
para
It's
su
in the process of being
cumplimiento,
finalized for purposes
contando
of
con este plan
implementation,
estratégico
and
nacional
it will
contra
provide
el
a
cáncer,
national strategic plan
en el
against
cual muchos de
cancer
sus
overall.
componentes
And
se están
many of the
trabajando
components
con el
are
apoyo
still
de
being worked
OPS.
on with the
Muchas
support of
gracias.
PAHO. Thank you very
Trabajamos
much
porque
to
la
PAHO.
Estrategia
So
Nacional
we've
para
been
la
developing a
Eliminación del
national
Cáncer
strategy for the
Cervicuterino. Y
elimination
por
of cervical
supuesto,
cancer.
esto viene
And
a generarnos esta importancia de crear documentos
this
normativos
means
que
that
nos
we now
ayuden y nos den
had to
la
create
línea y la guía
standards
para
and
cómo
rules
mejorar,
that
cómo
provide the guides
implementar
and
y hacer
guidelines
nuestro
on
trabajo.
implementing
Todo
the
esto
law
también
and improve our
tenemos que
work.
hablar que esto es un proceso en los años
As I said earlier, this is
generar la
a whole
estructuración de los
process. We
programas en
need
la
to
Secretaría de
first structure
Salud,
the programs
creándose el
in
área
the
de
Secretariat of
cáncer,
Health.
el
We
programa de
first had to
atención a
create
enfermedades
the
no
cancer
transmisibles,
area
lo
under
cual
the
ya nos permite
section on
también contar con
non-communicable
un
diseases.
presupuesto para la
So we
compra de
now
las
also
pruebas
have a
de
budget for this
VPH, para lo
purpose.
cual ya
And we now
estamos
have a
en
budget
ese
for the
proceso,
treatment of
¿verdad?
HPV.
De las
So
compras y
we are
ya
now
tengo
involved
también
in
el presupuesto
procuring
para el
the
próximo
vaccines
año.
and working on developing a
Hablando de los
budget for
pilares
next year.
de la
In
vacunación,
terms of the
los
pillars,
avances de Honduras y
the
esta
progress
información
Honduras
por el programa ampliado de
has made
inmunizaciones, en el
is
2016 Honduras
based on the
incorpora a
information
20
provided
naciones
by
la vacuna de
EPI.
VPH
In 2016, we joined the
tetravalente para
national
las niñas de 11
vaccination
años en igual que 2 dosis.
schedule
Para el
for girls
2024 se
11 years
realiza
of
el
age
cambio
with a 2-dose system. And in
ampliar la
2024,
edad
we
las niñas
expanded
de
the
11 a
program
15
to
años
increase
en
the
el
age of
esquema
girls from
de
11 to
una sola
15
dosis.
years of age with a single doses of
Esto
the
ha
vaccine.
permitido
This meant has meant that we now have, in 2024, we have a coverage of 12-year-old girls now reaches 91%. And we are now working on closing the gaps for those girls who are above, older than 11 years of age, so that we can attain more coverage for them. The vaccine is given freely through the healthcare systems or through schools, and we are looking at the possibility of decreasing the incidence by introducing a male cohort and expand the range to other ages as well. In terms of the screening pillar, now that we have all the rules and regulations in place, the General Office on Population Risks has begun to change from moving from cytology to fulfilling the protocol. We now have included HPV test, visual inspection, and treatment at the first level of care. Before, a woman who received a positive test had to travel to have the colposcopy done in a hospital at the second level. But now we have begun doing this at the primary healthcare level, and we've been able to provide the following information. Of those women who have had their first screens, 7% are positive to HPV, and 17%, first time screening, 7%, positive test, 17%, VHP serotype, 28%, and other serotypes other than 72%. These tests have been done through donations and studies that have been done in the country with different institutions and bodies. We had to develop a design for how to care for the women, a flow plan for these women, and create those documents. And then we also had to study how we needed to train our human resources by providing information, revolving charts to provide the information, and how they could take this information to the healthcare facilities. We also developed an information system, a flow chart for it, so as to be able to provide follow-up for women. We set up a file where you could follow up the woman, and a document the woman could carry with her so that she could be reminded of consult visits and what has been done. This will also have developed a system for showing what progress has been made. I'm showing you some slides on the training of our human resources, for which we have a applied methodology provided by a school in Peru with the support of PAHO on training and on implementing the strategy so as to benefit the population in the different healthcare facilities. We've also worked on training volunteers to support the healthcare facilities so that they can share the information with women in the community, information on how to prevent cervical cancer. We've also trained human resources. We've had 28 workshops on secondary prevention with 580 participants, and the training is done, and we've also socialized the protocol for doctors, students in both a virtual and in-person workshops. This year, we've also achieved our third campaign to familiarize the population on the International Day Against Cervical Cancer. We had the participation of high-level authorities, other organizations that supported us. The UN Population Fund has been very helpful to us, has supported us extensively, and we've also organized activities for detection, for screening in the different regions. And you can see here how they've worked on this topic. We've also trained a national trainers team. They are supporting the training in the different regions. We have 20 regions in our country. And by May, we will have reached we will have completed the training of regional trainers so that they can continuously provide this service in each region, so that they can provide quality and follow-up on the training. We have also done research working with various organizations. We've published internationally and provided training provided by international trainers and experts. There's our neighbors, like El Salvador, for instance, been very helpful in providing this training. Now, what progress have we made in the country? We have the center called Ciudad Mujer, in the Pink Star, where the colposcopy tests are done. That's where they provide the treatment with acetic acid. These are the regions where we have, in green, implemented the screening, and with the procurement of HPV tests, we will now perform screening using the test. And in the yellow, we will have reached the 17 regions in the country by the end of the year, because we have trained them already and we have already delivered the equipment. So we will have reached 118 clinics for the prevention of cervical cancer at the first level of care. What's important to note here is that we now have a budget for preventing cervical cancer, a national budget for this purpose, and this has been used to buy equipment and to deal with the various issues that have to be addressed to prevent cervical cancer. Thank you very much for sharing with us. For allowing us to speak about Honduras' progress. Fantastic. Thank you very much, Dr. Figueroa. Excellent progress in Honduras. I think Honduras is a good example of how we are implementing the three pillars: the introduction of the HPV vaccine together with thermoablation in primary health care, and also the strengthening of services, also the development of a national elimination plan, and your focus on training, education, communication, and also on how you involve the community and create volunteers. That was excellent. Thank you very much. So you are, I think, in the right path for elimination.
Julieta, and see if we are ready to hear from St. Lucia. Do we have Julieta's presentation?
Yes, I have.
Okay, great. Thank you. If we could just show that, and welcome again to Julieta Casillas Frederick, Principal Nursing Officer in the Ministry for Primary Healthcare in the Ministry of Health, Wellness, and Elderly Affairs in St. Lucia. Over to you.
Okay, so good day again to everyone, and my apologies for this glitch. We are going to go right into it. So I am going to present on our strategy for towards cervical cancer elimination in St. Lucia. The outline, please. Next. Okay, so in this presentation, we shall look at, like I said, our cancer situation, looking at the various strategies and looking at those strategies under the three pillars, which is the HPV vaccination, the cervical screening and testing, and some level of management as it relates to precancerous lesions. And our final slide in looking at how do we plan to move forward in sustaining those achievements. Next slide. Okay, so just to share some data on cancer from our EPI unit, in 2022, as we can see, malignant neoplasms made up one of the 10 principal causes of deaths in St. Lucia, and that is a rate of 15.7 per 10,000. Next slide. In terms of morbidity and looking at the 5 new cancer diagnoses per year throughout the years 2020 to 2024, we can see that cervical cancer is right there, ranking between 3rd and 5th within those years. Next slide. So it does mean that cervical cancer is significant, and we need to be able to focus on cervical cancer prevention and looking at the strategies towards elimination. So in terms of cancer mortality, again, we can see we have 20 data from 2021 and 2022, and we see that in all of the cancers, cervical cancer again is right on top there, which is for both 2021 and 2022. Next slide. Okay, so we have our 3 pillars that we've been hearing about this morning in terms of the 3 pillars towards elimination of cervical cancer, where we need to vaccinate 90% of our girls, 70% of screening, reaching out to women by the age of 35, and of course, 90% of some form of treatment. Next slide. So as we look at our HPV vaccination coverage, sorry, not coverage, but in terms of our schedule. So HPV vaccination was introduced as part of the life course approach and part of our vaccination for adolescents in grade 6. So as you look at the adolescent column, you will see that it was part of our routine vaccination for our grade 6, and it's co-administered with diphtheria and tetanus and polio. Next slide. So our HPV vaccination was first started in 2019 as a school-based program. We offered it at wellness centers as well for those mothers who had some hesitancy vaccinating at the school, and also offered within pediatrician offices. And we have 5 private pediatricians that work alongside us and promoting our vaccinations. The vaccine is offered to both boys and girls, and it has been this so from first introduction. And the whole purpose of that was to be able to assist with the uptake of the vaccine. And like I've indicated, it's co-administered. And of course, the vaccine is free of cost within all of our communities, all of our public health facilities. Next slide. So this is a graph showing what our coverage has been for the past 6 years. As I indicated, in 2019, we had a coverage of 53%. Let me just indicate here that in 2019 up to 2022, it was a 2-dose schedule until we changed to a single dose in 2023. Of course, we know we were hit very badly by the pandemic in 2020 and 2021. So you see how our coverages had been quite low. However, we were able to pick up. And of course, we are proud to report that for both girls and boys, our coverage for 2023 and 2024 has been 82%. So hopefully we can get to that 90% within the next 5 years. Next slide. Okay, so as it relates to cervical screening, under our universal health coverage, which was introduced, this is a policy of the government that was introduced in 2023, sorry. We started with a basket of services for maternal and child health. And last year, August of 2024, of course, it's a phased approach. And so we moved over with cervical cancer screening and also prostate cancer screening for the men. So as it relates to cervical cancer screening, these screenings have been strengthened to ensure that it's available at all of our primary care facilities, and to some extent to some private facilities, private physician offices, and also to ensure that we had an agreement with the lab in terms of a service level agreement to be able to conduct the testing, because previously we did not have the necessary analyzers to be able to do the 2 high performance tests that we have introduced in terms of the liquid-based cytology and the HPV testing. So we have an agreement with one of our labs, and this has been ongoing since August of 2024. Before we introduced, of course, we had to have training because this was a new technique in collecting the samples. And so we had training with all of our staff, our midwives, and the OBGYNs within the primary care facilities to ensure everyone had the competence of collecting those samples. Of course, we developed key performance indicators, and we also developed standard operating procedures and clinical guidelines. Next slide. So this is just a graph showing our women who come forward for screening, and of course those we go to as well in terms of increasing access. Over the years for 2020 into 2023, these are the years that we had not yet introduced the new technique, and also in terms of women not having to pay out of pocket, because that's the whole intention of universal health coverage, and to ensure that the service is available, affordable, accessible, and there is equity. So having introduced this new technique and clients and women not having to pay out of pocket, we saw, of course, an increase in the number of screenings that were conducted. Over more than 1,000, we have up to 3,000 there for 2024. So we can see, and that is just between August of last year into December. So we can see there had been a marked increase in reaching women out there so that they can have the necessary screens done. Next slide. So this is just showing here in terms of the analyzer and the form that accompanies the samples. Of course, the midwives and the nurses and doctors, they need to complete the form to be able to present it with the sample for processing. Next slide. So in terms of our protocol for the testing using the liquid-based cytology test, so we have women ages 21 to 25 years. Okay, we will do the cytology testing. If the cytology result is abnormal, then HPV reflex testing is done. And the reflex testing will only be done in cases with high-grade lesions. For women who are over 25, we will do the HPV testing. If it is positive, reflex cytology, and of course, management of those cases will be done based on the HPV test results and the extent of the abnormal cells. Next slide. So there are some special cases, of course, as we heard earlier in the presentation, of course, for women who are immunocompromised. We will, of course, have the pap smears done and after their first sexual debut or after the first sexual intercourse. For special cases where we have adenocarcinoma in situ and carcinoma, we will, of course, they must be referred to the Colpo clinic for that test. And of course, in case of cancer cases, of course, they are referred to the gynecologist, to the oncologist, sorry, after they've been seen by the gynecologist. Next slide. So when we commenced our liquid-based cytology and HPV testing, one of the other activities that was conducted is to ensure that the colposcopy was available within the primary care facilities. So since then, we have 4 clinics where we have colposcopy being conducted, and an additional 2 clinics are to be added within this year into next year. So we do have a distribution of that service across the island, so women have the service within close reach of where they live, and they can be followed up in a timely fashion. Next slide. So this again is our protocol in terms of our management of our cases. So with atypical squamous cells, which excludes high-grade squamous intraepithelial lesions and higher injuries, these cases are referred to Colpo, in addition to those who are HPV 16 and 18 positive, the L-cells as well. And also we have the protocol in terms of at what time the liquid-based cytology tests need to be carried out based on that result. So I'm not going to go through everything here, but we can see on screen the cases that are referred immediately to Colpo based on results, the repeat smears within 3 to 5 years, those that need to be repeated after the last cytology, and of course, if the HPV test is positive, at what time the test needs to be repeated. Next slide. So in terms of our sustaining our achievements, and this goes through the 3 pillars, across all 3 pillars. Public education is extremely, extremely important. I remember when we first introduced the HPV vaccine, yes, we had the mass media, the PSAs, the testimonials, giving all the information. But what has worked tremendously well for us is the small group and the one-on-one discussion. So we have for HPV vaccines before administration, where the team they go into the schools and they meet with the parents. They meet with the PTAs and they have a discussion. There is room to answer any questions, any concerns that parents have. And it's a similar thing for women who still have this fear of coming forward to do the cervical screens. So a one-on-one small group settings in terms of educating and informing works extremely, extremely well. And that's in addition to other communication strategies that we have in terms of brochures, leaflets, and posters, and so on. Health facility and workplace screening. Again, this has worked extremely well. Yes, we have clients who come into the facility, but we also go to workplaces. Once we can get a private room, then of course, we will be able to offer the women the cervical screen. This works very well with persons who work Monday to Friday, do not have the time to come to the facility. So we have persons who work in the banks, with the hotels. We have this kind of partnership with them where we actually go to the workplaces and offer cervical screens once a private space can be identified. Opportunistic vaccinations and screenings. So clients may not have an appointment, however, if they to come to the clinic. However, if they once they present to the clinic, or we have this kind of engagement with any of the clients out there, whether it be women for cervical screen, or whether it be a parent of a child or a child who comes to the facility, we use that opportunity to inquire about their status, whether they have been screened, whether this child has had the HPV. So we use a lot of opportunistic moments to be able to screen women and also to offer vaccinations. Health promotion activities during Cancer Awareness Month, we use that platform to be able to promote and to encourage persons to come for screening and for vaccinations. Community outreach activities, another one, which is a house to house. This is something that's very popular within the primary care facilities and communities, where we reach out to persons within their home to provide information to them and also to give them appointments where they can come in to do their screens. One of the discussions that we've been having over the years is really to have a mobile unit where we can actually go to those distant communities and to be able to conduct cervical screens. So this has been a discussion, and hopefully we can get to that point where we'll be able to reach more persons within the community. Training of healthcare workers, of course, in techniques. So it's ongoing training to ensure that our samples are of high quality and they can give us quality results. Advocacy, we have worked with persons who are advocates for vaccines, and also in terms of women, encouraging other women to come forward to have their screens. Partnerships and collaborations, like I indicated before, we work very well with civil society, with organizations, with the workplaces, and to ensure that we can get our message out there, and also we can reach more persons with our messages and with screening. I have already spoken about the communication plan, and we continue that. We have developed a surveillance, because in all of that, surveillance is extremely important. So we have developed a surveillance manual that is also going to support and guide us. So I think this is the last slide. Next. Yeah. So I want to take this opportunity for thanking the host, the team from Power WHO, for giving us this opportunity to share on St. Lucia. And I also want to wish everyone a happy vaccination week. Thank you.
Thank you. Thank you very much, Julieta, for this wonderful presentation on St. Lucia's efforts to eliminate cervical cancer. And, we see a strong focus on information, education, counseling, community involvement, community outreach, and we're certain that these strategies will help contribute to achieving higher coverage for HPV vaccination, screening, and treatment. So thank you very much for sharing that example from St. Lucia and inspiring us. Pasamos ahora a Brasil y quiero
Now we're going to hear from Brazil. Here I wanted to call on Dr. Ana Goretti, who is working on a vaccine against HPV in Brazil. So she is from the Ministry of Health. Ana, please go ahead. We can't hear you. I don't know if you are muted, maybe. But your presentation is on the screen, but we can't hear you.
Oh, ahora sí.
Ahora sí.
Now we are hearing you.
Yeah.
Yes, go ahead. We were able to hear that comment. Hello, everyone. Just a correction. I am here at this event, and also with me is Ana Catarina. She works with the National Immunization Campaign. I'm only the technical person responsible for the vaccine development. So I'm pleased to be here with you to share Brazil's experience in terms of our efforts to eliminate cervical cancer. So this is my first slide.
Estão vendo?
Can you see my slide?
Sí, sí, pasó. Estamos viendo.
Ok, então.
Great.
Só um minuto.
Just a second.
Ok. Bom,
Okay.
eu gostaria de dizer para vocês que o Brasil, como já foi
I
falado,
wanted to tell you something that you already know, and that is that Brazil has a campaign to eliminate cervical cancer. And this has spanned all of the areas of the Ministry of Health. We work with the cancer control programs and others. And now this is being presented in May on the 23rd. It is being presented to all of the municipalities, the regions of Brazil, so as to seek support from the different secretaries of the different regions, different areas, so as to support the three pillars of PAHO's project to eliminate cervical cancer. And here, I wanted to take a second to talk about vaccination, and that is exactly the part that we're in charge of here in the National Immunization Program. Now, with this, we have been implementing for 11 years. We have been using the vaccine for 11 years now when it was introduced to the country. So we are vaccinating both boys and girls, teenagers of both genders. This is a priority for their national immunization program. And here I wanted to report on some of the progress that we have made during these 11 years of implementing the program. And also I wanted to talk about those challenges that still exist. Now, why is this a priority? Why have we given priority to eliminating cervical cancer in the country? And just like in the countries in the Americas, the infection with HPV is a public health program. Right now, cervical cancer is the cancer, the third most important one in terms of the effect on Brazilian women, and it's the fourth cause of mortality. And also, in this way, we lose mothers, wives. We have had about 7,000 deaths of women per year in the country. So here we have studied the prevalence of HPV infections in the country. This was a national study, and it was the first study that reported and that gave us a whole picture of HPV infection across the country. It was composed of two phases. First of all, we did a basic study so that we could compare those initial results with the second phase. So the first phase was 2017, 2018. The second phase concluded in 2022. And we were able to see that the HPV infection in the country has a high prevalence. All the regions of Brazil with prevalences above 50%. You can see here the northern part of the country with 63.5% of young people between the ages of 16 and 25. That was the age range for the study that were found to be HPV infection positive. And it's in these states where we have the highest cancer mortality rates too. So this was a study that showed us not only the impact of vaccination in the country, but also it found demographic, socio-demographic, behavioral factors that had to do with HPV. And in phase 2, it's a study that showed us not only the prevalence of HPV that was being avoided, but also it was important because we were able to do oral testing too. So it was important. It was important that we did these studies because it supported the use of the vaccine here in the country and also shows the importance of control measures across the nation. Brazil also has important data having to do with mortality. It was part of a multi-center study working with other countries here, China, India, South Africa, Russia, United Kingdom, United States. And this study gives us an estimate of almost 11,000 deaths per year. That was in 2020 because of HPV infection. So this shows not only cervical cancer mortality, but also penile cancer, nasopharyngeal cancer, and other cancers that have to do with the HPV vaccine, showing that, in fact, this is a serious problem in our country. Now, here, I wanted to show you something that is important in terms of implementation. Here, we began to implement HPV vaccination after studies done in 2014. This was supported by a strong narrative. We began with girls between the ages of 9 and 13, and we also looked at impacts in other age groups, in other groups, in males, in the immunocompromised, immunodepressed population. And in 2016, we worked with girls between the ages of 9 and 13, young children, in this case girls, and then we worked with a population between 15 and 26 years of age. Then we included boys. We were the first country in the region to include boys. This is a gender issue, but also it was important to include them. Also, we looked at in 2022 women and men that were immunosuppressed between the ages of 9 and 45, and also children between the ages of 9 and 14. Also, we worked with persons living with HIV, also persons who had received a transplant, and oncological patients. And in 2023, we followed the guidance of WHO, where we introduced the vaccine for the victims of sexual violence. This is men and women between the ages of 9 and 45. Because we do have a lot of violence in the country. In 2023, we found that there were 800,000 cases of sexual violence per year. That means that we have a case every 2 minutes. Most of these are children under the age of 13. So it's important that we introduce the vaccine for that age group because these are people that are at greater risk of suffering abuse, and it's important that they be protected. Now, another important thing that we have in our country, and I think that this is a tremendous victory for us, is the availability of the HPV vaccine. We never had a lack of HPV vaccine in the country. The sustainability of the program has always been tremendously important. It allows us to guarantee our supply. So here you can see, and all of this was thanks to a transfer of technology that was done, but the international producer of the vaccine, a quadrivalent vaccine, to a national production lab. And now in 2025, we have a total of more than 75,000 million. That would be 75 billion doses distributed across the country. I have the data. I have the data here on the screen, and a large percentage, something like 4 billion doses, have already been applied, and the other doses are in the hands of the state and the municipal health secretariats. So also we provide donation to countries that need this vaccine. Another tremendously important thing, and this is something that was already said, and that is that in 2024, the country, following the guidance of WHO, and also in analyzing the experience in other countries, and all of this based on evidence from scientific studies, we adopted the single-dose regime. That was something that was done in the country. Now, in other countries, we know that sometimes they have a constraint in terms of availability of the vaccine. That is not a problem here, but we did analyze application of a second dose. Now, in a large country like ours, we think that one dose, being able to use just one dose, was very important, not only for the operations, but also it allowed Brazil to expand the size of its priority group, including people that were to receive the vaccine with no charge. There are many vaccination posts, and then based on our specialists and all of those decisions to expand coverage were well debated with scientific societies, also were discussed by our specialists. So, with our tag, and we thus included the immunosuppressed so that those could be carriers of recurrent respiratory infections. It's a very small group, but it is a group that can have a very serious effect, especially in children. There can be a respiratory obstruction even, and many, many recurrences. So here in Brazil, we have people at the age of 12 having 20 surgeries per year. Also, we're doing case studies since we have been vaccinating. What we have found is that vaccination in these cases really does reduce the number of papillomas, and also it reduces the number of recurrences and surgical processes, because treatment often is not effective. These are things that we're doing off-label, where we're using gum, and we are evaluating this measure, but we hope that this will allow us to improve the quality of life of these papilloma carriers. Now, I talked about victims of sexual violence and the use of PrEP. This is something that is being used preventively. Most of these are patients that are men having sex with men, young adults maybe, but we include the HPV vaccine as a measure because these are patients with a high incidence of anal cancer. And also there is a probability that they will continue to have HPV with very negative effects. Also, when we went to the single dose schedule, we knew that we had to make every imaginable effort so as to have opening to vaccine opportunities. And now in April, we began a catch-up campaign with adolescents between the ages of 15 and 19. That was a group that had not been vaccinated, had received no doses at all. Perhaps because of the pandemic, they had missed the opportunity of getting vaccinated between the ages of 9 and 14. So this was a campaign that covered the entire country. We prepared materials, we did planning, we got organized, we had meetings with the states, and this is taking place in the states, in the municipalities, and we hope that at the end of this year, we will have reached something like 7 million adolescents between the ages of 15 and 19, giving them at least one dose of HPV vaccine. And in April, we're working on a very important strategy for us, and that is the school vaccination campaign, so as to cover children between 6 months and 15 years of age. Here again, we're focusing on adolescents between the ages of 9 and 14. And also we're looking at those between 15 and 19 years of age that are still in school. Vaccination in school is the most efficient strategy to get broad coverage, and that campaign will last until the end of next month, May. And we hope that This is something that we can do with all of the vaccines on our vaccination calendar, and that includes HPV. Now, this is the first time we have done a catch up in the country, so there is a lot of planning that went into this. We set goals, and here we're talking about 121 priority municipalities where we have the 7 million adolescents that have received 0 doses of vaccine. So there, this is a vaccine that is guaranteed, and also we're working with surveillance. We emphasize the use of the necessary immunobiologics that would affect the event. Now, this is a vaccine for adolescents. There, Brazil has had taken very careful to avoid SAVI events, adverse effects to the vaccine. Now, another thing that has allowed Brazil to move ahead in terms of its HPV vaccination, and that is the work done with the states and the municipalities that have their health authorities. So the Ministry of Health provides the operational information. We vaccinate people, but basically it is the local organizations, secretariats that do the actual vaccination. There are millions of vaccination clinics. So we are the ones that do the planning. We look at the local realities and we look at the monitoring and what is happening in these states. So for us, that has been a major step ahead. Now, also, we work with other ministries of health in terms of the national plan to eliminate cervical cancer. We also work closely with international organizations, with PAHO, WHO. They are essential partners in the work that we do in vaccination. Also, our scientific societies, they are tremendously important because they include millions of professionals throughout the country. They are our spokespersons. They are the specialists who support us in terms of rules and regulations, and NGOs. NGOs are fantastic in terms of communication. Just to give you an idea, during the pandemic, it was NGOs that were responsible for all of the communication. They knew that this was a difficult period for us. It was hard for us to engage in communication, and they did a fantastic job. The National Congress, they too are involved. Right now, they have sessions in the National Conference, Congress talking about elimination of cervical cancer. Our senators, our representatives, and then our TAG. Our TAG is a key partner, and they have lent their support in terms of scientific issues, communication, and they have done a superb job. We're also working a lot with information systems, IT, because we cannot monitor blindly. We cannot identify the states and municipalities that are having problems and that require action where there are large numbers of people who are not vaccinated. So we need that data. We need to aggregate the data across states. In 2024, we introduced the vaccine as a single dose using a new cohort method, and that gives us coverage by municipality. You'll be able to see not only the cohort, but also a breakdown by age so that we can manage not only the program at the national level, but also at the state and municipal level. And in that way, we can look at local levels. And then a strong surveillance campaign. We have a pharmacosurveillance plan looking at cases of death, serious cases, and we have worked on training health professionals in terms of pharmacosurveillance at the state and municipal levels. And they're doing a fantastic job because Brazil went through a crisis. Here I'm thinking of the state of Acre, where they have the highest cervical cancer mortality. And that was having a national effect because that had to do with vaccinating not only against HPV, but also against other diseases. And it was the pharmacosurveillance effort working with the University of Sao Paulo that allowed us to clinically and radiologically assess these children, showing the population in Acre that they should not be afraid of the vaccine. That is another positive thing. Another thing that we are doing, working with USIP, which is working closely, and this is financed by PAHO, but there was a case given for healthcare professionals for diagnosis and for immediate care. Here, we have to avoid a recurrence of what happened in 2019. Also, we're addressing fake news, the anti-vaxxers. This is one of the vaccines that has been affected. The Ministry of Health works with different ministries, the Ministry of Education, and we have a program that is called Health and Conscience. And it is an interministerial initiative. And it aims at highlighting science, showing that there is reliable information on vaccination. And we have a WhatsApp group for the population where the population can find answers, all information having to do with the vaccines, correct information. Also, we have educational sessions. Also, we have social activities so as to disseminate information that points to the safety, the good use of this vaccine across the country. So this is what I call our major challenge. It's a challenge in all countries. Well before 2030, we have coverage not only of girls, but also with boys, 100%. And here you can see the cohort between the ages of 9 and 14. Here you can see 82%. And if you look by age group, you can see that the younger ages that should be vaccinated more have actually less coverage, but at the ages of 13, 14, by then the coverage is quite high of our girls. And what we're doing now is we're working with vaccination in schools, and this is a lot of work aiming at getting better coverage in the younger years. Here you can see the coverage that we have having to do with boys. It's important that you remember that the vaccination of boys began after we began to vaccinate girls. Only in 2017 did we begin to vaccinate boys. So here we can see our campaigns where we have created an awareness how important it is to vaccinate boys too, because they too are susceptible to HPV infection. And we feel that with this initiative, working with schools, and with our catch-up campaign, we feel that we are going to be able to reach the goal of vaccinating boys, and we will be able to do that through schools too. Now, all of that work, the work that we have been doing, the micro-planning and expanding the access and all of our health units, basically in terms of communication and the importance of emphasizing the effectiveness, the safety of this vaccine. We think that with this, we will be an assured success in our vaccination campaigns. Here, this is to conclude. These are the commitments entered into by Brazil in this new administration. This has to do with our efforts to eliminate cervical cancer, and it has to do with vaccination. That's a requirement that we are complying with. So we included all the priority groups between 2023 and 2024, and this shows the places where you can be vaccinated, the different age groups too.
portadores de papilomatose, e todos
Here,
são muito
the
grandes no Brasil,
carriers of
onde a gente
papillomatosis,
qualquer
that
coisa
was
que
a major
beneficie
discussion here in
a
Brazil,
qualidade de
but
vida
anything
dos
affecting the
portadores
quality
dessa
of life of the
patologia
carriers of
seria
this pathology.
extremamente benéfica e que a gente
It
vai
would be
estar
good
mapeando
to
a
work
questão
with those individuals.
usuários de PrEP, tá?
It,
Que além da
also
vacina
those
anti-HPV,
using PrEP.
agora também
And
contam com a vacina de HPV e
we
hepatite
have
A,
the
e a questão do
HPV
que a gente chama
vaccine,
no nosso
and
último
then the
compromisso,
catch-up,
a
which was
população
our most recent commitment
a
that we entered
vacina de
into
dose única.
when
A
we
gente tem
shifted to the
certeza que o
single-dose
Brasil
system.
está caminhando e fazendo
Brazil
todos os
is
esforços para que a
definitely
gente
making
tenha
every
no
effort.
futuro
We want to
os nossos
be certain
adolescentes de
that
hoje
in
possam
the
ter
future,
cobertura
today's
dos cânceres relacionados
teenagers
à
will
vacina
be
HPV.
cancer-free thanks to
Bom,
the
só
use of the
era isso que
HPV
eu tinha
vaccine.
para
So
apresentar.
basically,
Muito
that is what
obrigada.
I
Eu
wanted
não
to
sei se
share
a
with
Ana
you. Thank you
Catarina
very
quer
much.
fazer
I don't
algum
know if Ana
comentário.
Catarina
A
has
Ana
any
é a
comments.
coordenadora, além de ser
Ana
a nossa
is the
diretora do
coordinator
Departamento
and the
Nacional de
director for
Imunização,
the
é
National
coordenadora
Immunization Program.
da coordenação
And she
de incorporação científica e
is
normatização.
also the
Muito
coordinator of
obrigada a
scientific
todos.
cooperation. Thank you. I thank all of you.
Muchísimas gracias, doctora
Thank you
Goretti.
very much, Dr. Goretti. Ana Catarina, I don't know if you are there, and if so, I don't know if you have anything to add.
Parece que no.
Ana Catarina?
Ana Catarina, are you there?
Parece que no.
Vê lá, Ana Catarina.
Maybe she stepped away.
Eu acho que o link que foi para ela não permite ela falar.
Okay.
I don't know. Perhaps her link did not have permission to speak.
Ah, não. A Ana teve que sair a chamado do diretor.
Oh, I'm sorry. No, Anna had to, she asked me to speak because she had a meeting with the director. We were going to make that presentation together, but I guess she was called away. Well, thank you. Thank you, Dr. Goretti. That was an excellent presentation. And congratulations for the span, the scope of what you're doing in Brazil. All of those doses applied to girls and boys. So you're definitely on the path to elimination. Okay, we are beyond the time that we had allocated to the webinar, but I want to thank all of you for your commitment.
Silvana, por favor.
Silvana, please, please, here's Anna. So just a few words.
Okay, gracias.
Just a few words. Hello, Silvana. Hello. Our department wanted to express its appreciation for this opportunity. Thank you for asking Brazil to present. And it's important that we were able to discuss the HPV program. Ana Goretti, I know, did a great job. Now, it's important that we look at how we're facing this major challenge in Brazil right now with our catch-up campaign. Plus, we are working on the catch-up campaign, and we hope to conclude it by the end of this year. So thank you for this opportunity. No, I thank you, and thank you for all of your accomplishments to date. Especially, I congratulate you on having included other priority groups, and you're working with surveillance, the micro-planning, and also involvement of civil society, the universities, the NGOs. All of that, I think, has definitely made it possible to expand the coverage. Although we know you may not be at 90% yes, but you're definitely on the right track. Okay, we have gone beyond the time that we had allotted for the webinar, but I do want to conclude just by thanking all of you for being with us. Thank you for engaging, for being so interested in how we can expand the implementation of strategies to eliminate cervical cancer, reaching more girls, more women with screening, with treatment, and also with HPV vaccination. Also, I wanted to thank my colleagues. I wanted to thank Dr. Rasuri, Dr. Katz, Dr. Mauricio Massa from the Non-Communicable Disease Department, and also I want to thank Jacqueline Figueroa Julia Cassius, Frederick, Anna Coretti. Thank you for sharing your time and your experiences, because it's by sharing experiences, the challenges, how to deal with them, all of that is highly motivating. And when we hear about experiences and how you have dealt with pharmacosurveillance, how you are engaged in more active searches, how we can expand training. All of this motivates us to implement new strategies. So I conclude just by saying that I hope that in these 2 hours we have been able to provide you with more information, and I hope that we have motivated all of you. First of all, it's important that you realize that you can count on PAHO's support, everything that you're doing in terms of the HPV vaccination and how treatment has expanded so that all the countries in the region can work towards elimination. So thank you, and you can count on us. So thank you. Thank you, and enjoy the rest of your day.